So now that you've had your enteral nutrition, we'll talk about intravenous nutrition. My topic this afternoon follows from my conversation this morning, plus those of my colleagues. We'll talk about strategies for introduction of intravenous nutrition in preterm infants. So there's some guiding principles that we should start with around intravenous nutrition, and I call this intravenous nutrition. If I slip and speak of TPN or total parenteral nutrition, it's because that's what everybody says. But just like Dr. Bell and Dr. News spoke earlier, it's seldom that we give total parenteral nutrition to most of our preterm babies. So the first general principle is that the metabolic and nutritional requirements that are going on in a very healthy, nicely growing fetus do not stop with birth. The baby still keeps on living, still has oxygen consumption, and still requires nutrients. So immediately these are met by what's in the in the neonatal plasma and breakdown products from glycogen and amino acids in protein. So intravenous nutrition is always indicated when normal metabolic and nutritional needs are not met by normal enteral feeding. So those two guiding principles mean to me that intravenous or parenteral nutrition should start as close to birth as possible. And this means hours, not days. For the longest periods, infants should be allowed to not receive feeding, whether intravenous or enteral. The metabolic and nutrient requirements of the newborn, furthermore, are not different from those of the fetus. They might even be greater. So, babies don't stop needing nourishment at birth. It continues, and they therefore need to be fed right after birth, and their nutritional requirements are exactly the same, or as if perhaps even more than when they were as a fetus. So I'm going to talk about macronutrients in TPN solutions. And I call them, in this case, TPN solutions because they are intended to be for total parenteral nutrition. Most of the time, as I say, we aren't providing total. I'll talk about rates of infusion and effects and complications. So in terms of glucose, I've already introduced the subject. Adjust your intravenous glucose infusion rate to keep your glucose concentration normal. I'll talk tomorrow about hypoglycemia and hyperglycemia and continuous glucose monitoring as an approach to find out how often your glucose concentrations are not normal. But for the most part, keeping your glucose concentrations above 3 millimolar and less than 6 millimolar puts them right in the normal range. The less than 3 millimolar group may not have adequate glucose for normal nutrition. Now, 6 to 8 milligrams per minute per kilo starting right after birth. That's for full intravenous nutrition. But if you give 6 to 8 milligrams per minute per kilo right after birth, almost all the time you're going to run into a major problem that preterm infants have, and that's significant hyperglycemia. That's because newborn infants, whether they're preterm or not, and this happens clear down to 23 to 24 weeks gestation, immediately start producing glucose. They do this from gluconeogenesis as well as glycogenesis. What produces the glucose? Well, most of these babies are somewhat stressed. They do produce stress-reactive hormones. This is adrenaline and noradrenaline, or epinephrine, norepinephrine. And these hormones, the catecholamines, have the properties of inhibiting insulin secretion and reducing insulin action in the peripheral tissues. So double jeopardy, you add catecholamines from endogenous production because of stress, and the baby can't put glucose into tissues, so it stays in the plasma, and they become hyperglycemic. Glucagon, normal stress hormone, increases right after birth. It promotes glycogenolysis. It does this very quickly. And cortisol promotes both protein breakdown, providing substrates for gluconeogenesis, the amino acids, and it produces, therefore, more glucose by gluconeogenic mechanisms. There's also a secondary factor with the catecholamines. Once you saturate catecholamine receptors throughout the body, instead of having a negative feedback, it's a positive feedback because the periphery assumes when the receptors are saturated that there's still a need for more catecholamines. And so when you give catecholamines exogenously, you infuse epinephrine, norepinephrine, you end up producing more endogenous catecholamines, more adrenaline, noradrenaline. So, and for example, as measured in several studies, when you infuse dopamine throughout the pharmacological range that we use, or dobutamine, there's anywhere from a 2 to 6-fold increase in the concentrations of these hormones in the plasma. That doesn't come just from the intravenous infusion. It comes from this positive feed-forward cycle, saturated receptors, increased catecholamine production. There's a nice picture here just to show you what happens. This is, again, a study in the fetal sheep, and this is glucose. I had to have a hard time reading this. It's an old figure. Plasma glucose concentration, higher glucose concentrations. And this is a curve in which there is, these are the plasma insulin. So no matter what your insulin, if you happen to have catecholamines around, you don't get a very high insulin secretion rate when you have catecholamines. So at any glucose concentration, the presence of catecholamines lowers your insulin secretion rate and your plasma insulin concentrations. That's a fairly dramatic response. We don't measure this in babies, but it goes on just as well as it does in this fetal animal model. Then we do things that we probably should not do. Most of us have backed off on high-dose Decadron to treat pulmonary disease. It did that very effectively, lowered your respiratory requirements for a ventilator and lowered your oxygen requirements, but it certainly caused neurological problems. Decadron, just like cortisol, promotes gluconeogenesis and protein breakdown. We also infuse lipids, and we often give more lipids than the baby needs for actual energy production. Lipids provide carbon, and so that carbon simply substitutes for glucose carbon. So the higher your plasma-free fatty acids because of lipid infusion, the higher your glucose concentration will be simply by competitive inhibition or competition. Lipids also promote gluconeogenesis. They do this as shown in this schematic, which is a little hard to see, but this is the gluconeogenic pathway. There's glucose and there's the precursors all the way down here. Fatty acid oxidation produced by metabolism within hepatocytes produces a variety of cofactors, all of which have the capacity to stimulate several of the enzymes in the gluconeogenic pathway. So as you raise your plasma-free fatty acid concentrations, those are oxidized by beta oxidation in the liver. Those hepatocytes now start producing glucose by gluconeogenesis, activated by low insulin, suppressed perhaps by catecholamines, and enhanced then by the addition of lipids. What about persistent hyperglycemia? It has its own problems, so we try not just to worry about the first day or so of life when you have this reactive process of catecholamine-induced hyperglycemia, but if we sustain high glucose infusion rates with continued high glucose concentrations, we may run into some other problems. We don't see really the old-fashioned problems of fluid and electrolyte and acid-base disorders. They still are there, but those aren't nearly as common. But I think we're missing something about insulin and resistance and glucose intolerance developing. Here's another one of those studies we're able to do in our fetal animal model, where we infused glucose into the pregnant ewe, the mother, or directly into the fetus and produced chronic hyperglycemia. And as you can see, this is just GLUT1 and there's GLUT4, but unlike the hypoglycemic case, where we saw an increase in the GLUT1 and GLUT4 transporters, with chronic hyperglycemia, we suppress in all tissues GLUT1 and GLUT4. So there's less transporter capacity to take up glucose from the plasma. And so that ends up producing, even at high glucose and insulin concentrations, a reduction in glucose utilization rate. Whether it's glucose stimulated or insulin stimulated or both, glucose utilization rate is depressed because you simply don't have the transporter capacity to allow glucose to leave the plasma and go into the cells. Now, that's the experimental fetal model. We haven't done this study really in babies, a little difficult to do. But here's a study in neonatal piglets, so we add another model, and these are neonates, not fetuses. These are those that were on intravenous infusion of amino acids and so forth, and that's the insulin area under the curve compared with intravenous feeding, and this is the insulin area under the curve for enterally fed neonatal piglets. That's the glucose area under the curve, and that's for intravenous feeding, and that's the glucose area under the curve for enteral feeding. So as you can see, intravenous feeding promotes a condition of glucose intolerance and insulin resistance. So just like we produce in the experimental fetal model, the neonatal piglet model shows the same thing, and I wouldn't be the least bit surprised this is going on in our preterm babies. So a lot of the reasons we may find that we need to keep increasing nutrients is because we have less effective insulin secretion and insulin action. We also can do damage by simply giving more nutrition than the preterm baby needs. And we've talked about that already in response to one question about too much in the way of amino acids to a baby that doesn't need it, and the growth-restricted baby who maybe can't use it. So too high of a glucose infusion rate can have adverse effects. Most of these are seen once you get above 14 milligrams per minute per kilo, but they all start well below that. Much above 6 to 8 milligrams per minute per kilo of glucose infusion, you start seeing these problems. You get increased energy expenditure because you start producing lipid from glucose. That's an energy producing requiring process. So your energy expense goes up significantly. You increase, therefore, your oxygen consumption rate. That produces more carbon dioxide as you oxidize the excess glucose, and that may be difficult for the respiratory system that already is stressed in some of these babies. You produce fat in disproportionate to protein gain, and so you end up with fat. Well, if it's just subcutaneous fat, so what? But it's not. You end up with fatty infiltration of the heart and liver, and those are pathological processes. So what do you do about this? You treat persistent, very high glucose concentrations with a reduction in glucose infusion rate, since almost all of the time this hyperglycemia and most of its consequences are associated with just a very high glucose infusion rate. So if you're at 8, you reduce it to 6. If you're at 6, you reduce it to 4. You get much below 4 and you start running into the usual problems that you can't have a solution that's got that low a glucose concentration because it becomes so hypoosmolar that it runs the risk of producing hemolysis. So that's about as low as I go. Then you have to start decreasing your glucose infusion rate, and that produces your total fluid rate. And so you do run into complications. But that's the first maneuver. You can reduce your lipid infusion rate. This works, but not immediately. So maybe tomorrow when you come back to the nursery, you'll find that the baby's glucose is a little lower if you reduce your lipid infusion rate. You should always reduce your catecholamines. If you can do this by just good medical care, good for you. But most of the time we have difficulties reducing our IV catecholamine infusion rates because those were necessary to maintain blood pressure. Although lots of studies are showing that the amount of catecholamines we infuse to support blood pressure really aren't necessary, that we really are over-treating and saturating the system. We can normalize physiology with good medical care, and as I said, good luck on that. What about severe hyperglycemia? Well, we don't really know when it's severe. Severe means that the hyperglycemia is causing pathology in its own right, and I've given you some examples of what that might be. But I think if you asked 100 neonatologists around the world what severe hyperglycemia is to them, you would probably get 100 different answers. We don't have a definition in our own neonatal intensive care unit in our own group of neonatologists. Some will start treating with insulin because they think the glucose is too high when it's above 150 milligrams per deciliter. And others in the group, and I'm more on this side, wait until it's above 250 to 300. There, unfortunately, is no rational scientific evidence that either one of those or anywhere in between makes any difference, and we certainly don't know for what duration, how rapidly it got there, or what other complicating factors might be going on that would help us come up with better definitions. But at any rate, this is a standard low-dose infusion rate, and most of the time this will lower your glucose concentration fairly quickly, and you need to be careful then that you won't get rebound hypoglycemia. What are the benefits of doing this sort of insulin treatment? Well, it will reduce hyperglycemia. It does it almost immediately. It will reduce the associated hyperkalemia. Make sure your kidneys work, though, before you get too far along with this treatment. And then you do have reduction in hyperosmolality from lowering both the glucose and the potassium. This will decrease amino acid release from protein breakdown as a source of gluconeogenic substrates, but that's probably not a major benefit. So there are some cautions. The first is that there's no evidence that insulin infusion to enhance nutrition and growth makes any difference to them. I've told you about this before. Please read the Nurture trial. I think that's a very nice discussion of the fact that despite all the best intents of trying to keep glucose concentrations normal with insulin infusions, growth did not improve, and they did run into lots of problems. They noted much more frequent hypoglycemia. They had increased lactate concentrations, which by themselves are not a problem. Lactate's not a bad anion to have around, but it's the proton that accompanies it. So you ended up with lower pHs. You had hypercarbia and tachypnea, all of which are probably not good for your fragile preterm baby. Insulin does not promote glucose uptake or utilization by the brain. There are no GLUT4 glucose transporters that are insulin responsive on either the on any of the cells that allow glucose to get past the blood-brain barrier and into neurons. So do not think you're going to improve the one organ that really does always need glucose, and that's the brain. Insulin, as I've already said, actually makes the baby fatter, and then there are negative feedback mechanisms. When you try to promote the insulin to increase the synthesis of proteins from amino acids, negative feedback mechanisms are very quickly activated so that you do not end up with a much greater synthesis of protein just when you give insulin. So it really doesn't work as a growth hormone in that regard. There was only one significant study that I've been able to find, and it was reported in the Cochrane reviews, of insulin infusion and versus reduced glucose infusion as approaches to treating hyperglycemia. Both were equally effective over time, and that was variably defined, but at least by over 24 hours, both approaches lowered the glucose concentration much closer to the normal range. There also was no difference between these two approaches in all of the age and weight groups studied for the significant complications that everybody is fearful of. There was no difference in the rate of death, sepsis, retinopathy prematurity, necrotizing enterocolitis, intracranial hemorrhage, chronic lung disease, the number of days in the NICU, or the rate of growth. So if you're trying to treat a high glucose concentration, lower your glucose infusion rate, do the other measures I spoke of, and don't worry beyond that. There's an example of how fast insulin can lower your plasma glucose concentration. That's pretty quick. Be careful, therefore, that you don't get even lower. But what Professor Micheli showed in this anecdotal review was that he then started infusing amino acids. And over time, what they found in their unit was that with hyperglycemia, hyperkalemia, starting intravenous amino acids, not just glucose infusion, reduced the hyperglycemia, hyperkalemia syndrome almost to zero. He's since retired, so he doesn't claim that this is still going on in the unit that he worked in, because they're much more liberal in how much glucose and amino acids they're providing, but it is not a major problem for them. This is old data, and I just throw it up anecdotally so that one approach to treating hyperglycemia is simply to make sure that your overall nutrition is good, and particularly amino acids. Every amino acid that I know of, when studied independently, increases insulin production when it's going from a very low concentration to a normal concentration. If you go too high, you can suppress insulin production. So it may be that just getting your amino acids started early will help prevent the hyperglycemia, hyperkalemia syndrome. Here's one study showing intravenous nutrition started very early. These were 26-week gestation babies. They were started on this early total parenteral nutrition regimen at 1 hour of life. That's pretty aggressive. 1 hour of life, 3.5 grams per kilo per day of amino acids, and 3 grams per kilo per day of lipid. It was not a large study, but I think you could see that there were really no major changes in things that you were worried about, and particularly the glucose wasn't higher, it actually was lower. I don't think it was statistically lower, but at least it suggests that this kind of a regimen with the high amino acids was not that much of a problem. Which is better, lipid or carbohydrate, to promote the utilization of amino acids for synthesis into protein? Really not a good study anywhere out there. This is one that's relatively recent, 2008. I haven't seen one good one since then. But weight, linear growth, and head growth all seem to have significant increases relative to a higher fat diet when the diet was primarily carbohydrate as the source of energy. So enough lipid to provide for essential fatty acids. Adjust your glucose infusion rate to keep your glucose concentrations normal. Do not try to give more than that, and everything's going to work out just fine. Those of us who work in the newborn intensive care unit know that that's not always true. So lipids. We start at birth, 0.5 to 1 grams per kilo per day. When I say at birth, well, usually the doctor writes the order, and the nurse starts the lipid infusion somewhere by the next morning. So it's not an immediate order, but it does happen within the first 12 to 24 hours. How do we monitor this? We do what everybody else does. We measure triglycerides because that's real easy. It's actually one of the cheaper measurements to come out of the laboratory. Does it really tell you how well lipids are being used? No, I think it really tells you how they're not being used. So if your plasma lipids go up, you probably don't need to give as much, and that's about as simple as it is. Do not assume that this is a sign of toxicity. I don't know that hypertriglyceridemia anywhere up to 300 or 400 milligrams per deciliter is a problem by itself. And the same study I pointed out earlier, giving 3 grams per kilo per day starting at an hour of life, their triglycerides weren't any different from the group that didn't get them quite so aggressively. There's essential fatty acid sufficiency of 0.5 grams per kilo per day. It's mostly balanced in our products in the United States towards omega-6 rather than omega-3s. Hopefully that will change with some newer formulations coming along. But with low energy, all fatty acids, essential or otherwise, are oxidized. So if you don't give fat, you're going to eventually end up with fatty acid deficiency. That will include essential fatty acid deficiency, and that starts happening within 2 or 3 days of birth. There's some practical things. Of course, you all know that you don't use 10% solution. You use a 20% solution to decrease the adverse effects of high cholesterol, phospholipids. Carnitine, Dr. Bell brought this up. We don't use the solution of lipid that has carnitine in it. No study that I know of has shown that over 2 to 3 weeks of life following birth in preterm babies, carnitine promotes lipid oxidation. For babies that are guaranteed to be on intravenous nutrition for longer periods, carnitine is used fairly regularly. The studies are really not that great for what it does, but it may be of some value in promoting the long-chain long-chain fatty acids transport into mitochondria. Extremely low birth weight infants have lots of reasons why they don't tolerate high doses of lipids. I've already brought up the issue that some of them probably don't have a lot of insulin around, although giving them insulin has not seemed to promote lipid utilization and oxidation. Infection, I'm not quite sure how infection limits lipid metabolism. Probably does this by increasing catecholamines, which is natural, and maybe you're infusing catecholamines, and that simply increases lipid turnover, but that's not going to increase lipid utilization. It's simply going to increase plasma fatty acid concentrations and triglyceride concentrations. Severe lung disease, there have been lots of concerns about infusing lipids into babies that have bad respiratory disease, but that's because of the omega-6 group and the production of prostaglandins and other vasoactive products. Usually you have to have lipid infusion rates of 5 to 7 or more grams per kilo per day before you run into those issues. Surgical stress, steroid use, hyperglycemia, cholestasis, we see these all the time. What about amino acids? I already talked to you about the need for more amino acids as you're a smaller, more preterm baby, because you need a higher protein synthesis rate to support the higher fractional protein turnover rate and the higher fractional growth rate, and that these values diminish as you get more mature and natural growth rate slows down. If that's what's needed, and Dr. New already introduced this subject earlier, so why, despite all of this evidence that you need protein to grow, do people still not give sufficient amounts of intravenous amino acids and enteral protein? And most of the reasons why were rational at one point, poorly substantiated, and now historical, and maybe even hysterical. So some of the problems revolve around the issue of that very low birth weight preterm babies simply won't use the amino acids. They're fragile, they're stressed, and they simply can't use them for normal metabolism. And the data show quite the opposite. First off, protein losses are excessive. The lower the birth weight, the higher the protein loss. That's a 2,000 gram baby. That's a baby less than half that size, but about twice the protein loss rate. So if you don't give amino acids, these are babies that were only fed intravenous glucose, protein breaks down, amino acids are both used for oxidative purposes or lost in the urine. And this happens dramatically, and a small baby of 700 or 800 grams can lose most of its protein stores fairly rapidly. But if you give amino acids back, good things happen. So this is 1 gram per kilo per day, and this is 3 grams per kilo per day. And it looks like 1 gram per kilo per day. This is a study in our unit, and we stole this value from Dr. Bell's original study back in, when was it, Ed? In the late 80s, published in the early 90s. It looked like 1 to 1.5 grams per kilo per day was necessary to achieve neutral protein balance, which means you don't grow, but you're not going to disappear either. But that's 3 grams per kilo per day, obviously significant, and that gives you a protein balance over 1 gram per kilo per day. Not a rapid gain. Remember, you're supposed to be growing at around 2 to 3 grams per kilo per day at a minimum at this early gestational age. So still not enough, and that's why I can show this graph going all the way up to 3 grams per kilo per day, positive correlation with amino acid intake to protein balance. Our studies now are up to 4 grams per kilo per day. We are not going above 4 grams per kilo per day. We're staying right at 4 for the babies under 1,000 grams. But this curve goes up all the way through 4 grams per kilo per day, suggesting that maybe in some babies 4.5 might still be okay. I don't think that's necessary for normal growth rates. Another concern, the excess amino acids won't be oxidized, and actually they are. There's leucine oxidation, and that's leucine intake. Leucine's an essential amino acid. If you give enough, and this is getting up close to the normal leucine requirements for normal protein synthesis rates to support 3 to 4 grams per kilo per day for protein turnover. Very tight correlation curve, the same idea that this is correcting a deficiency disorder. What about uremia? Everybody's concerned that if you give high doses of amino acids intravenously, you're going to get a high BUN, and that's bad for babies. First off, I don't know of studies that talk about or that really provide rational data about what that urea is doing in the plasma or any part of the body, including the brain. Remember, uremia causing brain suppression, brain neurological suppression in adults, in animal models and older children occurs way above 100 milligrams per deciliter. So what do we see? This is serum BUN, and that's our 1 gram per kilo per day dose. Pretty normal BUN, that's grams per deciliter. That's on 3 grams per kilo per day. So it did go up, but I don't think any of you would, I don't think any of you would worry about these particular BUNs. Why does it go up? That's a good sign. That's because the amino acids are being oxidized, those that aren't going straight into protein. The urea cycle is intact, so the ammonia that's produced from the oxidation of the amino acids is being detoxified into urea. And as long as the kidneys are working in the baby, and I think that's the crux of the issue, many of the times we see the BUNs going very high, it's simply because there's poor kidney function. There's BUN versus amino acid intake, and this is in the very small babies. These babies are all less than 1,000 grams. So I don't think anybody could say there's much more than a very slight positive correlation. And guess what? That's just what I showed you. You ought to have a slight increase in your BUN if the amino acids are successfully being oxidized. The ammonia is successfully being detoxified to urea. And this shows BUN versus non-protein calories. So that's glucose and lipid calories. And again, that's not a significant positive correlation. So adding more energy to try to promote the oxidation or limit the oxidation of amino acids and push them into protein synthesis just isn't going to work. You don't do much of anything. So energy is not going to make the BUN go away either. It's just not that big of a deal. What about high amino acids causing problems because babies are stressed? They have high catecholamines and cortisol concentrations. Actually, they do pretty well. These are babies that are not quite as preterm as many of the babies are that we treat. But these were babies that had major surgery, were on ventilators, were receiving fairly high-dose sedatives and analgesics. That's a SNAP score and an NTIS score. These are scores of severity of illness, and those are moderate severity scores. These are babies in red fed 1.5 grams per kilo of intravenous amino acids, and that group fed 2.5. And whether they were on, this is the fentanyl dosage about the same and the dopamine dosage about the same, fairly moderate dosages, but still significant enough that they were needed for medical care. And that's the change in BUN, and that's the change in ammonia, and those are perfectly normal values. In fact, those BUNs to me represent that there's probably not enough protein going into the baby. That's not an anabolic situation. So stress by itself doesn't really seem to cause the trouble. Same data, but this is simply looking at it by balance and stable isotope technique. The higher dose of amino acids produced better protein gain, despite those babies being on ventilators, having had major surgery, and having catecholamine infusion rates and so forth. Another concern, IV amino acids won't be tolerated because of the quality of the IV mix is not good, just not a good solution. Well, that's where I started. I won't tell you how many years ago, but it was a long time. We started with a solution produced by a company that was designed based on egg albumin, which is a perfectly good nutrient for you and me. But that's very high in the non-essential amino acids, good for gluconeogenic support, not good for protein synthesis. So actually, the companies that have subsequently produced formulations of amino acids better designed for preterm babies, higher in the branched chain amino acids and overall higher in essential amino acids, are really doing pretty good. 1 gram per kilo per day, the blue bars 3 grams per kilo per day. And these are the essential amino acids. So going up from 1 to 3 produces higher plasma concentrations of amino acids. And there's your non-essential amino acids. not quite as many of them going up quite as high, and that's exactly what you would expect with a solution. In this case, we were studying trophamine, the one that's commonly used in the United States, that is more balanced towards essential amino acids. And there's a best case scenario. Weight gain went up, nitrogen balance went up, leucine went up, and the toxic amino acids or potentially toxic amino acids actually went down. I won't say that those percent changes are anything universal at all, but that was a best case scenario. I'm going to skip that one and go to this one. So is that where we should stop? And the answer is obviously no. Because what we did then was, instead of just looking at 1 gram versus 3 grams, we took our high dose, 3 grams per kilo per day, and compared it to normal plasma amino acid concentrations in the mid to late gestation normal human fetus. And this is this data from that umbilical blood sampling program in Milan. This is from Irena Cetin, and she looked at values in the 2nd trimester and the 3rd trimester. These are all essential amino acids. They knew these babies were normal, not at the time they did their sampling, because they were sampling for genetic purposes and for infectious purposes. What they did was, if they didn't find an infection and they didn't find a genetic problem, and the baby was delivered at term, healthy and of normal size, and everything else was fine, they could then say, okay, back then when we drew the sample, that was a normally growing healthy baby. You can see that at 3 grams per kilo per day, for most of the amino acids, that dose produces plasma amino acid concentrations equivalent to the normally growing human fetus. But there are 2 of them where the plasma amino acid concentrations were reduced by 50%, less than normal. Now, these are essential amino acids. So now these are the amino acid concentrations that are limiting growth. You cannot grow faster than the most limited of any one of the essential amino acids. So there still is room for improvement. This is trophamine. Many other studies, that's now owned by B. Braun in Germany. There are many other solutions out there, but this study, as far as I know, hasn't been repeated to show this kind of an issue. We've been trying to get a study organized to look at supplementing trophamine with threonine and lysine, and maybe in a year or 2 I'll have some data to tell you about whether we could improve things with more of those 2 limiting amino acids. What about the provision of amino acids earlier, like right after birth versus later? Only a couple of studies, and this is just one from the Neonatal Research Network. So that's one group that got a fairly aggressive dose of early amino acids, and that's the more conventional group, so that by about 12 days of life, there was not any difference in their amino acid intake. Now, this period of 1 to 2 weeks, I've already shown you, and this has been brought up several times, there's very poor growth anyway. Most of the babies simply do not grow. We don't feed them very much. They have lots of stress, lots of reasons why they might not grow. Nevertheless, this group did get more amino acids over the first week of life or so. And when looked at later on, the early amino acid group had a higher weight. The length was slightly increased, but significantly so. The head circumference was slightly increased, but significantly so. When you looked at them at 18 to 22 months corrected age, only the head circumference stayed slightly greater. Well, maybe. At least it wasn't reduced, so there was no sign of toxicity for giving earlier amino acids. Whether this turns out to produce better neurodevelopment will be something we'll have to come up with in longer-term studies. Dr. New showed you the study from the Neonatal Intensive Care, the Neonatal Research Network that Betty Vore followed up on. There may be an improvement in IQ. I'm still in favor of all of this, but I'm still skeptical about the actual results, and I think we need many more studies to look at longer-term neurodevelopmental outcome. Then what about toxicities? Hyperammonemia. There's the change in plasma ammonia in a control group and a group supplemented with not only intravenous amino acids, but higher dose glutamine. I think you can see that there's no difference in the ammonia, so that one we can toss out. What about metabolic acidosis? Well, we do see a slight increase in protons because insulin goes up with higher dose amino acids. And that insulin is going to metabolize glucose to oxidative metabolism and also to lactate. And lactate production carries a proton with it. But when you look at a number of different studies, none of them showed a change of significance in any of the metabolic observations of lower pHs or higher PCO2s. So I don't think that one's an issue. I've told you already that insulin doesn't promote growth. I think the real issue that already was brought up by Dr. New is that there are consequences of IV feeding only and no enteral nutrition. We'll hear more about that. I stole this figure from Dr. New so he can follow up on it, or maybe Dr. Martin will. If you have no food in the GI tract because you're only feeding intravenously, you end up with mucosal atrophy. You don't produce the trophic hormones that promote gut development. There's a significant increased risk for systemic inflammatory response, abnormal function of the immune system in the gut, and increased problems with polymorphonuclear attraction, and so that there's a significant risk of increased sepsis. And all of us run the risk of intravenous solutions, not by themselves, but because of having catheters invasively into blood vessels. Whether it's a peripheral vessel or a central vessel, there is significant risk of inducing organisms. Our favorite one, if I have to use the word favorite, certainly the most common, is Staph Epidermidis. We see this a lot. We've now gone through a fairly strict protocol of very tight control over the insertion of any intravenous line, not just central lines. Any intravenous line is done as if it is a central line, if the catheter is going to be in place for more than 24 hours. And we've now gone from, I don't know, over 100 days in a year of complications of sepsis to around 2. So we've reduced essentially almost to 0 our IV nutrition, intravenous catheter-associated sepsis rate. So it doesn't mean the problem will go away, because once you have a catheter in place in a baby with immune deficiency, which preterm babies tend to have, that's going to be a problem. So let me summarize. Fetal versus very preterm neonatal nutrition sort of summarizes my first talk and why we use intravenous nutrition more aggressively right after birth. Normal fetal nutrition, what happens? The placenta actively, energy-dependently, using active energy-dependent transporters, takes amino acids from the maternal plasma and pumps them uphill to higher concentrations in the fetus. So that's a pump of amino acids into the fetus. Those that are not used immediately for both growth and oxidation are simply passed out in the urine, which is good for the fetus because it can put that into the amniotic fluid, but then it re-swallows that. So this still is the potential for net gain. The rest of them simply are used for metabolic purposes. Glucose is taken up only as it's used because it's transported according to a concentration-dependent mechanism. So whatever mother's glucose is, the fetus will produce a glucose concentration dependent on its utilization rate. If it uses more, the glucose in the fetus goes down, and that increases the gradient, so there's more transported across. But at no time is anybody or anything pumping glucose into the fetus. In contrast, here's what we do in the normal preterm baby. We don't treat it that way. We pump glucose, not amino acids, into the baby. We pump it at rates higher than the baby can use, and we end up with hyperglycemia that we then have to go through all sorts of efforts to treat in ways that are not physiological at all. The excess load producing hyperglycemia then has lots of complications associated with it. And the amino acids, in contrast, aren't pumped into the baby at a high enough rate. They're pumped in less than the baby needs for growth. Some of them are used for oxidative metabolism, and the baby ends up protein deficient and can't grow very well. So I suggest we do something different, that we follow the fetal pattern. We start feeding the baby by pumping amino acids intravenously at 3 to 4 grams per kilo per day, or whatever age-adjusted protein infusion rate we ought to use for that baby's gestational age. The excess amino acid load, if we actually are producing one, will be passed out in the urine or oxidized, generally both. We provide glucose to meet energy needs. We don't need more than this. We need to monitor it more carefully so we can adjust up or down our IV glucose infusion rate to achieve normal plasma concentrations. And we provide lipids more for essential fatty acids than for just total carbon. So start IV nutrition at birth with a separate line. Central's good. Provide just what you need or what you can get. Use other lines for volumes, antibiotics, cardiotonics, analgesics, and sedatives. This is our standard approach. We only get TPN or TPN solutions, intravenous nutrition solutions, once a day. No matter what time of the day we order them, they only come to us from the pharmacy once a day. So if a baby's born at 5 in the morning and isn't going to get a standard order until 11 o'clock in the evening, what do we provide? We use a solution of 2% amino acids and 10% dextrose, and we give this starting at somewhere around 60 to 80 mils per kilo per day. At 80, it gives you 1.6 grams per kilo per day. No, this is not 3 to 4 grams per kilo per day. It's less than half of that, but it is right at or slightly above what Dr. Bell showed years ago as the amount of amino acids necessary to prevent protein wasting in the baby. You can raise this intravenous infusion rate. That will increase your plasma amino acid load. If you need to lower it, okay, you're going to get less plasma amino acids. Maybe that's because you have to give something else, some antibiotics, a volume, or whatever. But you can co-infuse those along with this solution very nicely because there are not too many things that are incompatible with simply a stock solution of 10% dextrose and amino acids. That's our guideline, and I'd be happy to share that with you at any time, but I don't think there's anything magic here. These are fairly standard dosages of things you probably use. And I'd be happy to send this to you, but it's probably not going to be different from what you're starting in your particular unit. Thank you very much.